Hello, I'm Ryley Enz, a second-year resident in the Maine Medical Center Emergency Medicine Program. I wanted to discuss echocardiography. This presentation will cover the basic views of echocardiography in the emergency department, but also go beyond those basic views to discuss more in-depth principles. The goals of this video are to review the basic views and expand upon them, to teach new views, and to also assess valvular pathology. There are 3 divisions in this video with titled slides, so those of you already familiar with the basic views might want to skip ahead to the portion where we discuss new views in valvular pathology. The first view is the parasternal long axis view. If the ultrasound packaging has a cardiac mode, the probe marker is pointed towards the patient's right shoulder. If the ultrasound is set on a basic mode, the probe marker is pointed towards the patient's left hip. The probe is placed to the left of the sternum. It doesn't matter where the probe marker is pointed towards as long as you can get this view. In this video we see a parasternal long axis view. Here in the video we see the descending aorta, the left atrium, mitral valve, left ventricle, aortic valve, aortic root, and the right ventricular outflow tract. You can assess the movement of the mitral valve to estimate the ejection fraction. If the leaflet of the mitral valve, right here, moves with each cycle up to the interventricular septum and touches it, then the ejection fraction is usually normal. You can also assess the overall motion of the left ventricle, right here, to assess for wall motion abnormalities or for global hypokinesis. Do you see the pathology? In this parasternal long axis view from the website Echocardiography in the ICU, there's a pericardial effusion. Basic echo assessment in the emergency department begins with the parasternal long axis view to assess for an effusion like this. Notice how the effusion appears anterior to the descending aorta. If the effusion were to appear posterior to the descending aorta, down here, then it would likely be a pleural effusion. When assessing the left ventricle, you can also watch for wall motion abnormalities. The interventricular septum is supplied by the left anterior descending coronary artery. If any wall motion, and the posterior wall is supplied by the left circumflex. If any wall motion abnormalities arise, you can estimate where the lesion might be. Wall motion abnormalities present with a lack of or decrease of wall motion. An objective way to estimate the ejection fraction with this view is to measure the E-point septal separation. This method is not the most accurate, but it is helpful. Use M mode and place the cursor through where the mitral valve leaflet approaches the interventricular septum. You can see a view here, the parasternal long axis view. Here's the marker, or the line that goes through, and this is where the mitral valve is, and it comes up here and hits the interventricular septum, so the line cuts right through. You can see how it matches up here on M mode. This is the tracing of the mitral valve coming up and hitting here the interventricular septum. If there's a distance between the septum and the leaflet, then measure it with the calipers. If there's a distance right here less than 0.7 centimeters, then the ejection fraction is normal, like in this. In fact, it's 0 because it's touching. If there's a distance greater than 1 centimeter, it's abnormal and a decreased ejection fraction. The next view is the parasternal short axis view. Rotate the probe approximately 90 degrees clockwise. If you're in cardiac mode, the probe marker will be facing the patient's left shoulder, and if you're in regular mode, the probe marker will now be facing the patient's right hip. Again, it doesn't matter where the probe marker is pointed as long as you can obtain this view. In this video, you see a cross section of the left ventricle and adjacent to it the right ventricle. Left ventricle, right ventricle. You can estimate wall motion abnormalities here by imagining a point in the center of the left ventricle, like where the words are, and checking to see if each portion of the left ventricle is contracting towards the center equally. Another method is to place your hand over portions of the wall and rotate it to assess and isolate portions of the left ventricle to see if there are any wall motion abnormalities. When assessing for wall motion abnormalities, you can estimate where the lesion might be in this cross-sectional view. The interventricular septum is supplied by the anterior descending artery, the lateral portion by the circumflex, and the posterior portion by the right coronary artery. For a more thorough review of wall motion abnormalities, you can look on YouTube under MMC ultrasound and find a good discussion by C.J. Fox, one of our previous residents. Do you see the pathology? This view can be used to assess for a pericardial effusion. You can see the effusion posterior to the left ventricle, down here, and some anterior to the right ventricle, just a tiny sliver right here. This person had a larger body habitus and the image is not perfectly clear, but can you see the pathology? In this parasternal short axis view, you can see that not all portions of the left ventricle are moving equally. If you place a dot in the center, you can estimate which portions are moving less. This patient had a previous LAD lesion and had persistent wall motion abnormalities. You can see right here, anterior portion supplied by the LAD moves a lot less than the posterior portion supplied here by the RCA. The short axis view can also aid in assessing the degree of right heart failure. When there is fluid overload of the right ventricle from right heart failure, the pressure can push on the interventricular septum. In this parasternal short axis view, you can see what is called the D sign. The right ventricle is pushed into the left ventricle so much that it makes it look like the letter D. In the short axis view, you can angle the probe to look at the apex of the heart and fan through past the mitral valve all the way to the base of the heart. Right here we start at the apex, we're moving up, fish's mouth, mitral valve, apex of the heart. The parasternal short axis view has focused on the mitral valve here, and it looks like the fish's mouth. Focusing on the base of the heart, you can see the aortic valve right in the center. Posteriorly, you can see the left atrium, the right atrium. You can see the tricuspid valve moving right here. This is the right ventricular outflow tract. If you squint, you can kind of tell that the pulmonary valves are right here. Now, keeping the same probe orientation as the parasternal short axis view and sliding the probe towards the nipple or under the left breast, you can obtain the apical four-chamber view. Often it is helpful to have patients roll onto their left hip and left shoulder to bring the heart closer to the chest wall. This is an apical four-chamber view. This is the left atrium, mitral valve, left ventricle, right atrium, tricuspid valve, right ventricle. The size of the right ventricle should be roughly 1/2 to 2/3 that of the left ventricle. This view can be especially helpful in assessing for right heart failure acutely from pulmonary embolism. Can you see the pathology? This is an image of acute right heart strain from a pulmonary embolism. You can see the right ventricle is no longer 1/2 to 2/3 the size of the left ventricle, but is the same size, if not larger. Can you see the pathology? Again, you can use echo to assess for pericardial effusions. At the top, right here, you can see the effusion surrounding the apex of the heart. The subcostal image of the heart is performed by placing the probe under the xiphoid process. The probe marker in cardiac mode is to the patient's left side, and in basic mode it is towards the patient's right side. Again, it doesn't matter where the probe marker is pointed towards as long as you can obtain this view. This is the subcostal view. You can see the anatomical landmarks here with the left ventricle, mitral valve, left atrium, right ventricle, tricuspid valve, and right atrium. This is a good view for assessing for pericardial effusions as well, especially when chest compressions are being performed on the patient and you don't want gel where your hand should go. By focusing on the right atrium and angling slightly towards the liver, you can get a good view of the inferior vena cava. It is helpful to rotate the probe 90 degrees. By asking the patient to sniff, you can assess for collapse of the inferior vena cava. This is especially helpful when dealing with septic patients and you're concerned for fluid responsiveness. If the inferior vena cava collapses 50% or more then they are likely fluid down. If the inferior vena cava is distended with minimal collapse, with normal respirations or sniffing, then they are likely fluid resuscitated. This is actually a normal individual probably needs to be hydrated a little bit more because of such collapse. This is the first checkpoint. Now we are going to go beyond the basic views and start assessing less common views for the emergency provider. Once we are in position for the apical 4-chamber view, we can simply tilt our probe inferiorly and we can change our view from the apical 4-chamber view to the apical 5-chamber view. This is the apical 5-chamber view. You can see that the apical 4-chamber view now has the aortic valve in the center, and you can see the left ventricular outflow tract right here, and aortic valve. And in some views you can actually get the aortic root. Again, starting from the apical 4-chamber view, you can rotate the probe counterclockwise roughly 90 degrees and you will obtain the apical 2-chamber view. In this video, the probe has been rotated 90 degrees counterclockwise from the apical 4-chamber view, and now you can see the focused image of the left ventricle, mitral valve, left atrium, and a portion of the left atrium that is important in thrombus assessment. This is the left atrial appendage. It is an important area of thrombus formation, especially in conditions such as atrial fibrillation. It is difficult to assess on transthoracic echo, and for this reason, transesophageal echo is used to assess the left atrial appendage for thrombus formation before electrocardioversion for atrial fibrillation is performed. Once in the apical 2-chamber view, if you further rotate the probe counterclockwise, you can obtain the apical 3-chamber view. The probe does not need to rotate a full 90 degrees. This video demonstrates the apical 3-chamber view, and you can identify the landmarks again of the left ventricle, mitral valve, left atrium, aortic valve with this left ventricular outflow tract, and the aortic root just barely right there. Next is the suprasternal view. It can be helpful in assessing the aorta. Taking the probe and placing it on the suprasternal notch of the chest can give you a view of the aortic arch. In cardiac mode, the probe marker is facing the patient's left shoulder with the probe resting right above the notch. With basic mode, the probe will be facing the patient's right shoulder. Too much pressure here is very painful, and so you need to use light pressure. Here you can make out the aortic arch right here, and you can appreciate some of the branching vessels off of it. This view can be helpful if you suspect aortic dissection, and you can watch for abnormal intimal motions here. As you see the lining here of the aortic arch, that's where you would assess. If you're having difficulty seeing the vessel, you can add color flow to ensure that you're in the appropriate place as you try to get a good view. Now we are going to change gears again and discuss valvular pathology, starting with mitral stenosis. The simplest ways to assess for mitral stenosis are to use the tracing function on the ultrasound machine and color flow. With a parasternal short axis view, you can focus in on the mitral valve to get that nice fish's mouth view. You can freeze the image in diastole when the mitral valve has its maximum diameter. Under the options or tools depending on your ultrasound machine, you can use a tracing function and trace out the circumference of the mitral valve to get an estimated area. This image is of a normal mitral valve, and the tracing provides an estimated area of 4.3 centimeters up here in the left-hand corner. In the apical 4-chamber view, you can put color flow over the mitral valve. When using color flow, recognize that the key in the left hand shows that blue is moving away from the probe and red is moving towards the probe. This video demonstrates a normal valve with red going through the mitral valve during diastole, and once the valve closes during systole, there is a blue as the ventricle contracts against a closed valve. No blue enters the left atrium. Notice how broad the red flow is because there is no narrowing of the valve to cause a jet. Red, blue, red, blue, red, blue, red, blue. After performing the trace function and getting the estimated area, you can compare it to these measurements. If the area is around 1.5 centimeters, it's mild mitral stenosis. 1.5 to 1 is moderate disease, and an area less than 1 centimeter is severe mitral stenosis. This video demonstrates a parasternal short-axis view of the mitral valve, and you can see that this fish mouth looks very small, right here. They did not trace it and give an area, but it correlates with severe disease. Then they obtained a 4-chamber view and added color flow. You can see during diastole, the red jet entering the left ventricle is very narrow. It is red going toward the left ventricle because it is flow directed towards the probe, but it is very narrow and represents increased velocity through a narrow opening right here. You can see that the flow is not broad and even like our normal example, but narrow and turbulent. Next is assessing for mitral regurgitation. Mitral regurgitation can be assessed with color flow. This is a normal apical 4 view with color flow on the mitral valve. You can again see red going through the mitral valve during diastole, which is appropriate. And then you see blue during ventricular systole, stopping at the mitral valve, and there's no blue entering into the left atrium. You see red, blue, red, blue, red, blue, red, blue, red, blue. This is an apical 4-chamber view using color flow, and you can see that during ventricular systole, there is a jet that enters into the left atrium. Right there. This is inappropriate and represents mitral regurgitation. It is mild mitral regurgitation. This is an apical 4-chamber view with color flow over the mitral valve. You can see during ventricular systole a blue jet moving away from the probe in the left atrium. This jet is large and represents a moderate to severe mitral regurgitation. Contraction ventricular systole causes a large regurgitant jet right there. This is a parasternal long axis view using color flow of the mitral valve, and here you can see blue entering the left atrium during ventricular systole again. This jet is a large jet and represents severe mitral regurgitation. Next, we can assess for aortic stenosis using color flow and Doppler. Here's an apical 5-chamber view using color flow over the aortic valve. You can see blue moving away from the probe during ventricular systole right here, as blood moves from the left ventricle through the aortic valve. You appropriately do not see any flow in the left ventricle during diastole. You don't see any red jets coming up after the blue jet. You also do not see a jet moving past the aortic valve, which would be stenosis. Here is a 5-chamber view with color flow over the aortic valve. You can see blue moving through the aortic tract, or the outflow tract, excuse me, going past the aortic valve during ventricular systole, which is appropriate. But you can also see a strong jet moving through the calcified and thickened aortic valve. See how it's white and calcified here and thickened? Blue coming through, and then you see the strong jet afterwards because of the stenosis. This is an apical 3-chamber view with color flow over the aortic valve, again demonstrating appropriate blue moving away from the probe during ventricular systole through the outflow tract and through the aortic valve. Blue going through, blue going through. But you again can see a jet moving through the aortic valve instead of a smooth, broad flow. You see a narrow jet. This again is aortic stenosis. You can use Doppler to objectively measure velocities. There are two options that you can use: pulse wave or continuous wave, PW or CW. Pulse wave, or PW, will measure between the two marks on the line. This is an example. I hit pulse wave, and a line appears, and here are my two parallel lines. Continuous wave will measure the highest velocity anywhere along the line, as compared to between the lines, between these markers rather. It is crucial that the ultrasound beam be aligned as close as possible to parallel with the direction of blood flow. And so here I chose an apical 5-chamber view because I wanted to measure the velocity of the left ventricular outflow tract. And so I tried to align it. I tried to tilt my probe to get an image that was as parallel as possible to this line. If it's not parallel, it will underestimate the velocity. So this image again is of a 5-chamber view with a pulse wave line measuring right at the outflow tract. Here you can see the measurements plotted as pulse waves. And you can see that they're measured in centimeters per second here. If it appears that these waves are going to be going beyond what pulse wave is able to measure, you can switch to continuous wave. So here again you see the apical 5-chamber view, but now with the continuous wave, and this function will measure the highest velocity anywhere along this line. And so I tried to make my 5-chamber view as parallel as possible with this line. You can see it's again measured in centimeters per second. And here you see that this plot maxes out at around 2 centimeters per second, or 200 centimeters per second, or 2 meters per second. So here are some measurements to consider. Mild aortic stenosis is between 2.6 to 3 meters per second. Moderate stenosis is between 3 and 4, and severe is greater than 4. This is a simplified approach to aortic stenosis. If you wanted to further characterize it, you could use the continuity equation. This goes beyond the scope of this video, but if you wanted to study it further, you could look in Otto's textbook of echocardiography, and I have the source at the end of this. Next is aortic regurgitation, and this can be assessed with color flow. Here we have again the apical 5-chamber view. You can see blue moving with ventricular systole appropriately going through the left ventricular outflow tract. You can see some going past the aortic valve. During diastole, there is no red flow moving past the aortic valve back into the left ventricle. This is an apical 5-chamber view demonstrating aortic regurgitation. You can see an appropriate blue jet during systole as blood moves from the left ventricle out of the aortic valve. But during diastole, as the ventricle expands, you can see an inappropriate red jet streaming past the aortic valve. This can be hard to assess because blood is also entering through the mitral valve right next to it. So we see an appropriate blue jet coming through But then while the ventricle is expanding during diastole, we see this red jet streaming right here. Stream, stream, coming through, coming through. You have blood coming through this mitral valve, which can kind of confound things. So that's why you have to look very carefully for a jet, a narrowed portion, like a flame. You can compare with the parasternal long axis view with color flow. Here you can see during diastole a strong jet moving past the aortic valve back into the left ventricle. What about the other two valves? Well, pulmonary stenosis is rare, and we're not going to cover it because of such. Pulmonary regurgitation is hard to assess. Often it's an incidental finding or a benign finding, so we're not going to go over it. Also, tricuspid stenosis is rare. If you're going to see it, it's probably from rheumatic fever. And here in the US, we don't see that often. But mitral regurgitation is a lot like, tricuspid regurgitation is a lot like mitral regurgitation. You can assess it with the apical 4-chamber view, and you just put color flow on it, and you watch for regurgitant jet. So references that I used were Pathophysiology of Heart Disease, Otto's Textbook of Clinical Echocardiography, which will give you all the information you need to know. Images I acquired myself or got from echocardiographer.org, web.stanford.edu, and also from Pete and Dave, my mentors here at Maine Medical Center. I also want to thank my lovely and beautiful wife for being the model for many of these normal echoes. Thank you very much.